Good morning, good afternoon, and good evening to those of you who are joining us live online, and also to the judges of the Megamind. Thank you for joining me with me today here. Today I'd like to share my story about how I discovered the socket shield technique as the ultimate and the best answer to the aesthetic buccal contour. Now, my name is Dr. Scott Jung, and I'm a dentist with a heart and passion for implant dentistry. I come from a beautiful city called Vancouver in Canada. And this is my clinic, Cloverdale Dental Center, where I eat, sleep, and perform dentistry every single day. Now, last year, I was very fortunate enough to make it to the last round of Megamind. And that experience really blew me away because I was able to meet all these clinicians from all over the world and learning and absorbing their knowledges and expertise. And that proved to be very invaluable to me. Now, and that was actually the reason why I was so hesitant to join this Megamind this year, because I knew the competition would be fierce and tough. But I know I had to join this because I know the last Megamind made me a better dentist who can serve my patients better. As the saying goes, what doesn't kill me can only make me stronger. So today, I'd like to start off my presentation with this particular picture. And this is a case that I did about 2 years ago. It's an immediate implant with immediate loading. And if you look carefully, you may notice something is a little bit off. Maybe you can see better in this view. Let me tell you this, immediate post-op, 3 months post-op looked wonderful in my eyes. But after a year, after 2 years, this is what I see. The buccal contour has collapsed into a concavity. Now, how many of you have observed the same situation in your own cases? Or is it just me? Well, this is actually not uncommon. It has been reported in the literatures many, many times. We know, despite the immediate implant placement, the labial palatal bone width still shrinks. And this one article, as an example, by Dr. Homley Wang, shows that resorption can occur up to about 18% within a short span of 12 months. And that's quite a lot. And so we begin to ask the question, why is this happening to us? Well, if you think biologically, it makes sense. As we all know, the alveolar process has 3 main blood supply. That is the periosteum, the periodontal ligaments, and the cancellous bone. Now, in the labial plate, especially the maxillary anterior area where the labial plate is so thin, it doesn't really have a lot of cancellous bone to rely on. And so we cannot really rely on that blood supply. So for us, then, in order to place an implant, we remove the tooth, thereby removing the PDL blood supply as well. And now it becomes evident. With only the periosteum blood supply remaining, that is lack of blood that dooms that labial plate for resorption. So now, when I first got into immediate implant therapy, my hopes were filled. I thought placing the implant, filling the buccal jump gap, dual zone grafting would have saved my tissue volume and architecture. But truth was, this is what I see. The buccal contour still collapses. Now, thankfully, this patient has low lip line and is not complaining. The implant is still doing good and surviving. But in my eyes, I think this case could have been done better. And it's an aesthetic compromise, if not a risk for failure. So let's talk about the case of today. This is Dave, 67-year-old male with many dental history in his mouth. Medically, he's a little bit hypertensive, otherwise pretty healthy. And one day he visits me with a tooth in his hand. His lateral incisor post-core crown complex has broken out of his mouth. And as you would imagine, there really isn't much for us to save. He wanted his tooth back, so naturally, we began to talk about implant therapy as an option, and patient accepts. Great. Immediate implant, immediate loading, I've done this before, I got this in the bag, right? But that first picture that I showed starts to come into my mind, and I begin to ask that question, what if? What if the same thing occurs? What if the facial contour still collapses and patient starts to complain? I wanted to do the better for Dave. But Scott, so what if you have a little concavity, right? As long as the implant is fine, Everything is good. It's good enough. But the thing is, I'm not happy with good enough. Now, once upon a time, our telephones actually looked like this. It's a dial-up. It's rudimentary, but it worked. And everyone was happy that they were able to call their grandmas 20 miles away and no complaining. But after a while, this phone turned into this, an iPhone with all the bells and whistles. How did that, a dial-up, transformed into an iPhone? Well, that's because there's always a small percentage of people who pushed for better, who seeked betterment. And those are the people who cut the cord from the dial-up, added a screen, pushing the boundary and bettering our world. I'm here to be better. Okay? I'm not happy with good enough because I don't want good enough in my mouth. I want the better and the best in my own mouth. And shouldn't we be treating our patients as if we should treat ourselves? So, how can I do a better, the best buccal aesthetic contour for Dave? Well, from what I know, there's two options available for us. Connective tissue grafting and socket shield technique. Now, as we all know, traditionally, connective tissue grafting is used to improve the buccal tissue volume. And this is a case example that I did. Okay? If you look, you can, after the addition of CTG, the buccal tissue volume has improved dramatically. But what about socket shield technique? Well, the idea was, instead of adding something into there, what if we are able to preserve the labial plate as is? That would have been saving that blood supply, which comes from the PDL attached to the tooth. And it's showing a lot of promise. There are some more and more data is coming out, and this one particular article shows the 5-year, there was minimal to no changes in facial contour. So we have the CTG and socket shield. Which one's better for us? Well, there's actually, unfortunately, a lack of data comparing both methodologies directly. But there's this one case study that I found. And you can see on the right central incisor that received the socket shield technique shows very minimal changes, up to no changes at 12-month mark. Whereas the left central incisor, which received the CTG, is showing some negative changes highlighted in blue at 12-month mark. So we can see maybe the socket shield is a better thing. Well, that makes sense in my mind because I believe preservation is better than compensation. That's because CTG is ultimately a compensatory mechanism. The labial plate still remodels, but this adding a CTG compensates for its loss, whereas socket shield technique is 100% preservative. From what I know, replanting to regrow a forest is a lot more effort than keeping the forest alive. So let's go to our patient Dave again. We have a situation with a broken tooth, and we want to place an implant in here. Okay? But if we know that placing just the implant, we're going to lose all this beautiful buccal contour. So, is socket shield the answer for Dave? Well, let's look at this article together. And this article summarizes the indication and the contraindication of socket shield very, very well. Now, I don't have the time to go through every item here today. And so I'm going to show you the 3 main reasons why I chose the socket shield technique as answer for Dave. The tooth was non-mobile. There was no peri-involvement, and unlike CTG, there was no need for a secondary surgical site, reducing patients' morbidity. So let's begin with the socket shield. Now, socket shield technique is a technique-sensitive thing. Partial extraction has to be done to remove a portion of the tooth, leaving the space for implant. And the implant placement must be so precise it does not disturb the shield, but also achieve a prosthetically ideal position. And to do all this in a small confined space like lateral incisor, wow, that's a tough job to do, right? But I know I wanted to provide the best for my patient, and I got the tools in order to achieve that. So we start with a challenge to remove a tooth, leaving a root tip inside. It's counterintuitive, but I confess, I have left root tips inside before, but it was never intentional like this. Okay? So In order to do this, we follow a certain protocol. And the protocol that I follow is by the PET kit from Megajet. And this kit has specific drills for partial extraction therapy. Now, as the literature recommendation we follow, we create the shield to create optimal stability. And crescent shaped in order to provide a maximal space for the implant. And we add an internal chamfer in creating a room for the tissue. And once it's created, this is what it looks like. And now it's time to place an implant. And in order to place an implant in a small, tight space like this, we need some help because one little slip and your osteotomy could be ruined. And so we utilize a guided surgery. R2Gate is my go-to. Digitally pre-planning allows us to calculate the exact position of the implant that's away from the shield and prosthetically ideal. And using the guide, we're able to perform the osteotomy and implant placement smoothly as possible. And this is what we end up with. Implant position well away from the shield in a prosthetically ideal space. And also 4 millimeters deep from the buccal margin in order to achieve zero bone loss concept. Now, to do all this perfectly, it took some time. Now, if we don't gain the initial stability here, all that becomes meaningless because we're not able to provide a tooth to our patient. That's what he wants, right? So to get that initial stability, not only does your surgical technique matters, but the implant design. And that's why we choose the blue diamond with the taper design and aggressive knife thread in order to gain that 45 newtons per centimeters. And this is what patient goes on with, a tooth in their mouth. Okay? Now, this immediate provisional was created using a 3D printed shell picked up intraorally on a temporary abutment with some flowable composite. Now, once it's picked up, a care must be taken care of in creating a proper emergence profile. The biological emergence profile is highlighted by this S-curve here. And if we don't do this, we would actually lose the tissue that we worked so hard to preserve. And this is the provisional in the mouth. And now notice the black triangle here. This is not a mistake because in about 2 weeks, you can already see the papilla filling in. And this is not magic. This is actually predictable because once we understand the Tarnow's rule, if we create the contact point within the biological limits from the interproximal lawn, we know the papilla will fill in given the space. An X-ray also shows a stable bone level with the socket shield peeking behind it. 3 months later, and once we remove the temporary prosthesis, look at that tissue, right? It's ready for final prosthetic. No tissue sculpting is needed because we already spent the time to create a perfect emergence profile. Here's the final prosthetic created with the custom abutment with zirconia crown and the tooth inserted in his mouth. Beautiful, right? And from initial presentation to here. Now, when we overlap these images, you may notice and appreciate how well the buccal contour has been maintained over time. And I was able to recently meet Dave and was able to see his tooth just like this. And what we notice is that the buccal contour collapse has not yet been repeated for this patient. And the CT showing the buccal shield still holding up the labial plate as well. So I can attest to you today that I've done my best for Dave with the best tools and the best knowledges that I have access to. And as you can see, the socket shield technique is a lot of work and effort to put in just one tooth. And so you ask, why do we do this? Well, that's because this is what I would want in my own mouth, and I would do the same for my patient. Now, I like to end this poem with a short poem, end this presentation with a short poem. Good, better, best, never let it rest, till your good is better and your better is best. Each day, there's always something new and better. As a dentist, as a doctor, we spend the time to learn the better in order to provide the best treatment for our patients. Thank you for joining me in this presentation. Thank you so much.